So Anita, you are which year now? And sorry, where are you getting trained? Anisha, can you hear me?
Sir, I can hear you. There is power cut. I'll just connect the laptop also. You cannot see my screens, right? कुछ भी कर लो something.
Vishnu madam, good morning. Are you there? Anisha, can you hear me? Am I audible clearly? You're on mute, I think. Yeah. Still on mute mode. Yeah.
Sir, now is it okay?
Yeah, I can see your slides. I can hear you clearly. Can you hear us clearly?
Yes, sir. Yes, sir.
Okay,
I can.
fine. You have a good connection and you are
Yes,
using a laptop. Okay.
yes, sir.
Yeah. No, I was just inquiring, where are you getting trained and which year?
Yes, sir. Sir, I am in DY Patil, Pune. I am doing my fellowship under the guidance of Dr. Girish Kakle, sir. I've just started. It's been 4 months. I've joined. I've done my MBBS and MD from Uttar Pradesh, Bharati Medical College.
Okay. So you're a postgraduate in medicine and 4 months into rheumatology.
Yes, sir.
Okay. Fine. Vishli, madam, are you there? We'll wait for madam to join.
Yes, sir.
Yeah, we have a minute. We'll have a quick introduction and then we'll just let your case start.
Yes, sir.
Madam, are you there?
डोलो पर भी दे रही
हाँ हाँ देखो जरा चल चल ऊपर आ जा
Okay, good morning, all of you. This is Dr. Sunil Kumar Singh. I'm a consultant in rheumatology with about 15 years experience based at Mumbai, Oklaban Hospital. I'm one of the moderators for today's MRA student-teacher interface, and we have Dr. Amisha presenting. She's a postgraduate in medicine and is 4 months into her rheumatology training with Dr. Girish at DY Patil, Pune. And the session will be taken by Dr. Lata Vishle and myself. Madam is a very senior rheumatologist and has been the recipient of the Best Teacher Award as well. And she is a teacher to many of us practicing in Mumbai. And so it will be great looking forward to this session. And we will allow Anisha to start her session right now. Anisha, you can start your case.
Good
thank
morning.
you very much thank you very much for the introduction and I welcome dear Anisha to start her clinic or her case presentation.
Thank you so much, ma'am. I am presenting the case of ABC. She is a 13-year-old female. The school dropout since 3 years, resident of Sholapur district of Maharashtra. The history was given by the father. The patient came to our hospital in December 2023 with the chief complaint of pain abdomen since 5 months. I would like to start my history from 2020, that is 4 years back. Patient at the age of 9 years developed pain and swelling joints, which involved both upper limb and lower limb. Bilaterally symmetrical, large plus small joint involvement involving the elbow, wrist, knee, ankle, and the small joints of the hands. It was insidious, progressive, additive, with early morning stiffness that lasted for 20 to 30 minutes. It was relieved with activity. The movements were painful and associated with fever, loss of appetite, recurrent mouth ulcers, and hair fall. There was no association with any skin rash, erythema, back pain, hip pain, or a migratory pattern, or history of trauma or psychological symptoms or nighttime pain associated with the joint pain. For this, the patient went to a nearby practitioner and was prescribed oral medications, and she got relief. As per the father, there was a weekly medication along with some small yellow medications and a small white medication, which was given twice a day initially and then reduced, and paracetamol for pain. In 2021, a patient was on treatment for the same, and it went uneventful. In June of 2022, patient developed generalized body swelling, which was insidious, progressive, first noticed as puffiness around the eyes, followed by generalized swelling of the upper limb, lower limb, and abdominal distension. It was associated with frothing in the urine, but there was no decrease in urine output, high colored urine, orthopnea, palpitation, or visible hematuria. There was no history of chest pain. For this, the patient got admitted in a hospital and was further investigated and managed medically. During the same episode, of course, during hospital stay, the patient also developed one episode of abnormal body movement, which was sudden. It was characterized by jerky movements of all four limbs, approach of eyes, frothing from the mouth. There was no tongue bite, no bowel bladder incontinence, headache, or projectile vomiting. It was accompanied with the had last.
Anisha, just wait. I
Yes.
request all the other participants to just mute themselves so that there is no disturbance and we can save time on these things.
The episode of was accompanied with post-ictal confusion that lasted for 10 to 15 minutes. As per the father, patient was treated with heavy doses of injections for 3 days and some and oral drugs were given and swelling. In August of 2023, that is 3 years after the first episode of arthritis and 1 year after the episode of anasarca, the patient developed pain abdomen, which was 5 months, which is since August and was insidious, progressive, spasmodic type, recurrent, diffuse, non-radiating, severe in intensity, aggravated 1 to 2 hours after food consumption initially and later became continuous. It was associated with nausea, vomiting, constipation, and anorexia. There was also one episode of blood and vomiting, which were 2 spoons and brownish tinged. It was not associated with diarrhea, yellow discoloration of eyes, melena, or blood in stools. There was no localized swelling in the abdomen or inability to pass flatulence. The similar pain recurred in November 2023, along with second episode of GTCS, when the patient got admitted and was treated with injectables and was prescribed a monthly injectable drug. In December of 2023, patient came to our hospital with the third episode of pain abdomen, similar in characteristic. The birth history, the child is first born full term normal vaginal institutional delivery. Immunization was completed, milestones were normal. Personal history, mixed diet, did not achieve MENARC, and she's a school dropout due to prolonged hospital stays. Family history, there is no history of diabetes, hypertension, CKD, CTD, or similar history, illness history in the family. There was no history of sensitive rash, tightening of skin, difficulty in opening mouth, or history suggestive of Raynaud's. No history of myalgia, muscle weakness, no sensory disturbance, or there was no history of dryness of eyes and mouth and dental caries. There is no history of cough, dyspnea on exertion, hemopsis, heartburn. Investigation and history. Oh, sorry, examination. On examination, the child was 140.
Anisha,
Yes, sir.
yeah, before you proceed with the examination, can you summarize the history and give us a differential based on history? What would you start thinking about in this child?
So initially, when the patient was 9 years old, she developed bilaterally symmetrical chronic inflammatory pain, which was upper limb predominant, and it was inflammatory type. And she initially presented as polyarthritis as a case of polyarthritis. Later on, she developed anasarca, which is indicating towards nephrotic syndrome, because there was no associated decreased urine output. There was just frothing of urine associated with and severe swelling that developed. So it is indicating towards multi-system involvement. There is arthritis, there is renal involvement, there is also positive finding of hair fall and oral ulcers, so indicating towards multi-system involvement. During the second episode, during the episode of anasarca, when she was probably in nephrotic syndrome, at that time she developed a first episode of GTCS. So there is also neurological involvement. And now she is presented with pain abdomen, which is GIT involvement, sir. So it is a multi-system involvement occurring at a course of 4 years, sir.
Fine. So yeah, so summary would involve that this is a 13-year-old girl with polyarthritis, with anasarca, with episodes of seizures and abdominal pain in that sequence, with
Yes.
your likely diagnosis. Yeah, that's what I wanted you to speak on. Absolutely. So you should be able to just quickly summarize and have few differentials in mind as to when you say multi-system involvement, what is your, so multi-system involvement with likely diagnosis of what?
Sir,
What
likely diagnosis of systemic lupus erythematosus, sir, SLE.
Okay.
Yes.
Just a minute. There's some technical thing with Bishli madam. Can you?
Yeah,
We can't.
I'm able to hear to you, but am I audible?
Now you're audible, madam.
I think I just want to ask her, because you have DY Patil Hospital has, Bharati Vidyapeeth has attended this patient when she is of 13 years of age with a multisystem disease, right? And the illness started at the age of 9 years, and it started with fever and polyarthralgia.
Yes,
Can you
sir.
give us
Yes.
the conditions here? A patient of 9 years comes to an adulthood to your hospital or to under your care, and she developed these complications. What are these illnesses which will progress from arthralgia to a nephrotic syndrome? What you try to narrate it out to us. Don't presume that the patient has lupus because you have got investigations with you. I want to listen to you. What are the conditions in a pediatric to the adult age which will progress from fever, abdominal pain, and then a renal disease? Did you follow the question?
Yes, ma'am. Yes, ma'am.
Yeah.
Ma'am, henoxaline purpura can present like that.
Name other conditions. What are other features of HUS, or say what you call as henoxaline purpura? What is not there in this patient? What do you understand by purpura?
Ma'am, rash history was not there, and that is why I was.
No, just tell whether it is there or not. Suppose this, do you think this patient has polyarticular disease and fever? What are the causes of polyarticular pain, stiffness, and fever? Let's
Ma'am,
come.
yes, ma'am. Polyarticular disease with a fever in a child could be due to infection causes like fever. It could be due to psoriatic arthritis. Reactive arthritis could be there. Then there can be JIA, which includes further oligoarticular, polyarticular, and psoriatic, and systemic JIA and undifferentiated arthritis.
Now, of these conditions that you mentioned,
yes, ma'am.
when the patient on treatment?
Yes, ma'am. Yes, ma'am. Initially, she was on treatment, and on taking the treatment history, she gave that she was prescribed a once weekly medication. And on going through the doctor, yes, ma'am.
Achha, okay, okay. You
Yes.
suppose this patient has remained untreated for a long time. Which particular disease in the pediatric age will develop a renal disease and abdominal pain? Let's try to learn the approach to a case.
Yes, ma'am. Renal disease and abdominal pains.
No, you say it is a polyarthritis, right? Polyarthralgia, polyarthritis, untreated. I'm giving a clue. Untreated, now progress to renal disease. Or name the arthritis that will progress to nephrotic syndrome. Which are the conditions, which are the diseases which are untreated and they go into nephrotic syndrome, hypoproteinemia, anasarca. Can you think of untreated rheumatoid or say GIA, which goes into amyloidosis? You said it could be psoriasis, which seems to be less likely because many times ankylosing spondylitis untreated can go into nephrotic syndrome because of secondary amyloidosis.
Okay,
right? There
Yes,
can be Mediterranean fever in a childhood age, which can go into nephrotic syndrome. So what I'm trying to find out from you is approach to a case which probably inadequately treated or the disease progressed to a stage that a patient developed nephrotic syndrome. What is definition of nephrotic syndrome to you?
Ma'am, nephrotic syndrome is when there is nephrotic range proteinuria, which involves 3.5 gram of protein excretion, and the serum albumin levels is less than. There is fatty cast in urine, and there is minimal hematuria and hyperlipidemia.
Hyperlipidemia. Okay,
Yes.
okay. How will you explain the abdominal pain that she has and hematemesis that the patient has?
Ma'am, the kind of history that of pain abdomen, it is
Causes of abdominal pain in a patient who has got nephrotic syndrome.
Ma'am, it can be due to ascites.
If it is massive.
Yes, ma'am.
When the ascites is massive, they will have tension and intra-abdominal pressure rise, and there can be other venous pressure problems. But why there will be pain in a patient with nephrotic syndrome? Which are the organs, which are the vessels?
Ma'am, due to bowel ischemia, it can occur.
Okay, the second thing, you suppose this patient develops renal angle pain, a gross hematuria, and you are bothered.
Ma'am, it is that will indicate towards TIN, interstitial.
Many times, this nephrotic syndrome patient, they have got hypercholesteremic tendency for coagulation. They can have renal pain or even renal vein thrombosis is very common.
Yes, ma'am.
Which patients of nephrotic syndrome will have hematuria? Not all patients will have. Which patients? Is there something called as nephrotic syndrome?
Yes, ma'am. Nephritic.
What is nephritis and what is nephrotic syndrome? Is there any difference between the two?
Yes, ma'am. Nephritic will have RBC cast and have gross hematuria.
No, clinically, how will you suspect?
Clinically, nephritic patient will present, ma'am, with less edema as compared to nephrotic, and there will be more of hematuria, and also there will be a history of oliguria or decreased urine output in nephritic patient.
And what will happen to the blood pressure?
Blood pressure.
Blood pressure.
Hypertension will be there in nephritic, ma'am.
Achha, okay, please remember, tell me types of hematuria. Hematuria.
Ma'am, hematuria can be hematuria is when there is presence of more than 3 RBCs per high power field in you. And a gross it is microscopic when it is not visible to the naked eye, and gross hematuria is when there is frank blood in urine.
Hematuria will be painful.
Yes, ma'am.
Which hematuria will be painful?
Which hematuria will be painful?
Or causes of painful hematuria. Common is renal stone, uretary stone.
Polyarthritis, urolithiasis, and stones. Yes, ma'am. That will be.
Not to forget is most of the patients with the diabetes, they will have papillary necrosis, papillitis. Okay? Okay.
Yes.
Right. When you say that this particular hematuria is of renal origin, what should be the other urinary abnormalities in such patient before you label that this is renal cause of hematuria, renal parenchymal cause of hematuria?
RBC cast, ma'am.
Right. Well, okay. So the presence of cast. Second,
then
there should be proteinuria, right? Proteinuria,
yes.
hematuria.
Pro-
Hematuria in renal disease is never isolated.
Yes,
It
ma'am.
has to
It's
come with
always
proteinuria and cast
and
as well.
RBC cast.
Okay. Okay. Go ahead, Adi. Sunil, you want to ask her?
No, just wanted to correct her that when Madam asked you fever with polyarthritis and you enumerated a lot of other causes, probably you were ignoring the fever. So when the question is very specific, like fever with polyarthritis, then psoriatic arthritis and JIA. So your first answer would probably be a systemic onset JIA among that group, because the others, fever may not be a common manifestation. Okay.
Yes.
So fine, you can go ahead with the examination.
On examination, she was 143 centimeter tall, weight was 25 kgs, BMI was 12.19, and BSA, body surface area, was calculated to be 0.97 meters square. She was fair in general condition. BP was 90 by 60 mmHg, right arm supine. Pulse rate was 114 beats per minute. Respiratory rate was 14. Temperature, saturation, and JVP were normal. Only positive finding in general examination was presence of pallor. And head to toe examination, there was no pedal edema, no lymphadenopathy. Head to toe examination revealed there was alopecia and there was redness in the eye, which was more in the right eye as compared to the left. Systemic examination on the CNS, CVS, both were within normal limits. There was no focal neurological deficit, and in CVS also there was no added sounds or murmurs heard. Respiratory examination was also normal. Chest movements were equal, and chest expansion was normal. Percussion note and normal vesicular breath sounds were heard. On a per abdominal examination, on inspection, the shape of the abdomen was scaphoid. There was no visible scars, veins, or discoloration or visible swelling. On palpation, there was diffuse tenderness in all the quadrants. There was a doughy feel, and there was no rebound tenderness or organomegaly that was appreciated.
Just wait here. What do you understand by doughy feel? Why I use this adjective? Why I use this word specifically doughy? Or duffy, whatever you say, like a dough.
Because it was not soft and it was not hard. It was more towards
No, once you use this word, that means you are giving me a diagnosis of tuberculous ascites. This particular word has got a definite meaning.
Ma'am, soft with flabby is doughy.
No,
So
when you say, you also said there was some tenderness or something you said, no? There
yes,
was no rebound tenderness.
No rebound tenderness was not there.
But I think you have to be very careful before you use this word doughy, because that gives me diagnosis of tuberculosis. If suppose this was TB ascites, can TB produce nephrotic syndrome?
Ma'am, TB can involve the lymph nodes, it can involve the mesentery, it can involve the bowel, it can involve other visceral organs as well. But it is very rare to cause nephrotic syndrome.
Untreated, listen to me. Untreated tuberculosis,
Disseminated.
untreated leprosy, untreated RA were the three important causes of nephrotic syndrome when I was learning medicine.
Okay.
I think the rule still states.
So what is it
And
that in the nephrotic syndrome of this characteristically untreated disease, what is the hint? What is the diagnosis that you're looking at as the cause of nephrotic syndrome in an untreated RA or a long-standing tuberculosis? That is what Madam is trying to ask you. The
Amyloidosis, sir.
good.
Okay, I just wanted to, you are given us the height and weight and everything of this boy, no? Boy or girl,
Girl.
she?
Girl.
Girl. Can you tell us, whenever a pediatric patient comes to an adult medicine practice or rheumatology practice, what are the things that you should be very careful before we start the treatment? Beside the physical growth, we also look for the gonadal growth. We
Yes,
also
ma'am.
look for the mental development, educational development. So what are the stigma that the boy or this girl was hypogonadic? How will you understand it? On examination.
Ma'am, there was no ma'am, there was no axillary or axillary hair growth. The puberty was not achieved. Menarche, she has not achieved menarche as per the history, and as per the examination, there was no breast development. It was breast development was not there. Secondary sexual characteristics, basically, they were not present in this female, which was indicated towards the fact that she was hypogonadal.
Okay, so this is very important when you narrated the examination. You are just totally escaped. It can happen because we many times we forget, right? But don't forget it. That's very important.
Yes.
What could be the reason for delayed puberty in her? Delayed puberty in her?
Delayed puberty in her could be, ma'am, because of
Suppose she had received some injections. You said she was given for 3 days and all that. So which is the probable medicine that she was given and then she was maintained on that medicine? Common drug that we use in practice? Corticosteroids, do they hamper the growth? Corticosteroids hamper the growth?
Yes, ma'am. She was given pulse. According to the history, she was given high doses of a 3-day injection, which could point towards use of corticosteroids, and that to stunt and development and delayed puberty as well.
Tell me something about hypothalamo, pituitary, and gonadal axis. Just name it. Which most of these corticosteroids, they will suppress it. Hypothalamo,
Yes, ma'am.
pituitary,
They will suppress.
axis.
Yes, ma'am. Because we are giving corticosteroids from the outside, they will suppress the hypothalamic pituitary adrenal axis, which will lead to decrease in the decrease in hormone productions from the adrenals and the pituitary. So there will be decreased ACTH production. There will be decreased growth hormone.
That I understood. Tell me about gonadal axis because her puberty is delayed, no? Many times the height is also disturbed. So what happens to the growth hormones? I just want to know from you. Because these are the issues.
Yes, ma'am. The growth hormone.
Okay. Is the growth hormone indicated in these patients then or not? Okay, you can read this.
Ma'am, to give growth hormone therapy?
Do you give or you don't give? Or it doesn't work? Okay, it's all right. You can read this topic. You can read this topic later. Okay? Because the younger brother will be taller or younger sister will be taller than this boy. Right? Okay, go ahead.
Yes, ma'am. The investigation and treatment history. At the time, yes, sir.
Anisha, again, don't go to the investigation. So Like we
Okay.
summarized in the history, you have examined the patient now,
Yes.
and you have some additional findings, and then again at the end of examination, based on your history and examination, you'll try to refine your differentials and say that now my differentials are these based on my findings. And then because investigations may not be available, say in a new case coming to you, the rest of the thing is not available. So is there anything that has got added on to your differentials of the exam history and then the additional findings that you've got, or your diagnosis still remains lupus?
So,
Or in short, I would put it as that what were you able to negate
sir,
and what were you able to confirm on your examination?
Forget
since
the reports in the case. Forget the investigation. Give a clinical approach.
yes, ma'am.
Huh.
Ma'am, since the patient has come to me only with pain abdomen only, and there is all the other findings were in the past. It was whether it was anasarca, that was in the past. Currently, patient has no anasarca. Currently, patient does not have any episode of seizure. Currently, patient does not have any arthritis or swollen joints. No systemic involvement is currently there. Patient has only come with pain abdomen to me. So when the patient initially came with pain abdomen to me and she gave me a history of a chronic illness for which she has been on and off medications, I was suspecting it to be, I was suspecting the causes of pain abdomen could be various. It could be due to infections. Number one, it could be due to infections because she was on long-term treatments for long-term treatment. Then she was on so many medications, so drug-induced gastritis and drug-induced other conditions can also be there. Since there was vomitings and pain abdomen, and it was related to in food intake, uh, it could be due to peritonitis, pancreatitis, paralytic ileus, any condition can present like that. So there can be multiple causes of this pain abdomen.
Okay, it's all right. Answer to
But since she
Sunil's question now. Sunil has asked a very beautiful question to you. You have to redefine your diagnosis, reorganize your findings, and give us. You still want to stick to lupus, or you would like to give us some differentials, taking into consideration the massive ascites that she has?
ma'am, currently she has no ascites.
Huh?
Ma'am, currently she had no ascites. Currently there is no anasarca. Currently there is no joint pain. There is no joint muscular.
So which is that
She
ascites?
only had.
Which is that ascites which will subside on its own?
Ma'am,
Was it a case of polyarthritis then?
no, ma'am, it was 2 years back that she developed generalized body swelling. We don't know what. Yes, ma'am. Currently, the only positive finding on examination were in the abdomen, which was just diffuse tenderness and a little soft to flabby feel on abdomen. And there was pallor, there was alopecia, and there was redness in the eye. The only positive finding on examination currently was this: there was no pedal edema, no sign suggestive of anasarca was currently present, ma'am. Even the joint examination was completely normal when she
So
came to
Anisha,
me.
you still say that at the end of my history and examination finding, my diagnosis still remains with the background history, a possible case of lupus with presentation of abdominal pain with the likely differentials of ABC, now combined with history and examination. That is how you would want to give a diagnosis.
Yes,
Yeah. So you can't say that the patient has
yes, sir.
presented to me only with abdominal pain and these are my findings. The history is already there with you. Then you have examined, and so suppose just say for example, suppose there were additional findings here. Uh, Suppose there was a palatal lesion that you could see. Okay. Or suppose there was some petechial
Yes,
lesions
sir.
that you could see. How will your differentials change with that? Would
What
you
do
have
PTK
anything?
suggest? What do the PTK suggest?
Ma'am, Behçet's, it can be due to
what is the cause of petechiae, hemorrhages or petechiae?
petechiae would suggest petechiae will occur in
Which cell is important? White cell, RBC, platelet. Which cell is important? And what that condition is called?
ma'am, petechiae can be due to ma'am, platelet is important. Platelet
So it will
thrombocytopenia
suggest
will
what
cause
it will suggest. What it will suggest.
it will suggest
Thrombocytopenia.
yes, ma'am.
Okay.
Yes,
Then
ma'am.
you asked me about ulcer. You know the conditions, typical ulcers in rheumatological conditions, their site, their presentation, pain, painless. What? Give some features of ulcers that you understand. Because you mentioned there is oral ulcer in this patient.
Ma'am,
What are the common causes of ulcers?
ma'am, ulcer can oral ulcers in
ulcer can be because of what? Suppose I take NSAIDs, will I develop ulcer? I take painkillers, will I get ulcers?
yes, ma'am.
Is the site of, no, I will try and get answer. Is the site of the ulcer important in rheumatology practice?
Yes, ma'am. Site of ulcer is important.
Which site is important?
Case of like a case ma'am, like in a case of SLE, the ulcers would be unilateral. They will be asymmetrical. They will involve the hard palate. They can involve the buccal mucosa. The site of ulcer is important.
So you know everything. You know everything. You are getting thought blocks. Okay. Which ulcers are recurrent? Which ulcers are recurrent?
You know,
Resistant to treatment?
recurrent ulcers resistant to treatment.
Resistant to treatment. What is aphthous ulcer? Why do you use the word aphthous ulcer?
Ma'am, pyoderma can be.
Okay. Do you know ulcers, genital ulcers, oral ulcer, or eye manifestations? Which is the disease?
Behçet's, ma'am.
Behçet's. Okay. So you must know some conditions with ulcers. That is a good answer. Chalo. Go ahead. Go ahead.
Go ahead.
The investigation findings at the time of arthritis back in 2021 were anti-CCP low positive, rheumatoid factor low positive. Her hemoglobin was found to be 8.5, platelet count 3.5, and TLC were 3400. ESR was 90. Urine RN reports were within normal limits at the time of arthritis presentation, and LFT, KFT, serum uric acids were within normal limit. The treatment she was started on was methotrexate, 10 mg once a week to increase to 15 mg once a week, and folic acid tablet thrice a week, paracetamol for pain, and prednisolone, which was started with 7.5 mg and reduced to 5 mg. At the time of development of anasarca or swelling all over the abdomen, her investigations reports in June 2022 suggested of anemia, which was 8.9. The TLC count was 6.6 and platelet count was 2.91. LFT, KFT, they were within normal limit. Creat was 0.5. ANA, because at that time she also developed an episode of seizure, and she was and urine routine microscopy had a proteinuria 3 plus. RBCs were 10 to 15 and they were granular cast present. She was undergone ANA by IF, which came out to be 1:3200 positive. C3 levels and C4 levels were also low, 25.4 and 3.17 respectively. dsDNA quantitative by ELISA was done, which was more than 800 and came out to be high positive. Her urine protein creatinine ratio was 3:1, and USG whole abdomen was done, which showed raised cortical echogenicity, but CMD maintained moderate ascites and bilateral pleural effusion. The CSF findings at that time, because during that episode of anasarca, she had one episode of GTCS. Her CSF findings was glucose was 68, protein was 74, WBCs were absent. MRI was done, which showed bilateral frontoparietal restricted cortical diffusion. MR angio, brain plus neck was within normal limit. There was ANA
Anisha,
blot that was
can we
done,
stop you there?
suggested of, yes, sir.
Yeah.
Yes, sir.
So what is there in that ANA report which is still missing when you say ANA by immunofluorescence?
Sir, there is no pattern. They have not mentioned the pattern here.
Okay.
It was not mentioned in the report.
And what do you mean by that 1 in 3200?
So, this is the dilution of the sera of the patient. When we put it on the Hep2 cells in immunofluorescent assay, we take fluorescent coated antibodies.
And so
With
the higher the dilution would mean what? Is it a strong report or is it a weak report?
stronger report, the higher the dilution, like even in higher dilutions, we are able to label the.
Based on the ANA report itself pattern, would you be able to guess what you will see in the ANA blot in terms of your antigens? Or because ANA blot is an expensive test and not everybody or all centers might want to do it. So if I tell you that this ANA by IF is a homogeneous pattern,
Yes,
then
sir.
what are you expecting?
So there are a lot of patterns that are recognized in ANA by IF reports.
No,
It
no,
can be
not lot of patterns. I am
the
asking you if it is homogeneous.
dsDNA is most common associated with homogeneous patterns, sir. Antihistone is also associated with homogeneous pattern.
Okay, fair enough.
Yes.
And you said about the C3, C4 being low. How do you interpret this? The C3, C4.
So they are also done by ELISA.
No, not the methodology. What do you make out of it
The
when you?
low level suggests active disease. If since we are suspecting the SLE here, low complement levels will suggest active disease. C3 is more specific than C4 because relative C4 deficiency can be normally also present in patients with SLE.
Are
So
there
C
any other conditions that you are aware of where the C3 would also be low, which is not lupus?
low C3 levels. Uh, um, could be so in cases of infection, sir, and
Okay. Infective endocarditis, gram-negative
yes, sir.
septicemia.
Gram-negative septicemia infections, sir. Then there can be hypocomplementary urticaria, skin conditions that can be associated with
Hypocomplementic urticarial vasculitis. Okay.
vascular.
And suppose your C3 is normal and your C4 is only report which is very low. Does that give you any clue to any
So
other disease?
low C4. Early complement deficiencies, sir. Early complement deficiency can be due to.
So if I have a person coming to you with recurrent angioedema and you have asked for a C3, C4 report and the C3 is relatively normal and C4 is very low, does it give a clue towards what type of angioedema we are looking at? Okay, I'll save some time. So hereditary angioedemas have C4 values low and sometimes they're used for monitoring, and cryoglobulinemia is an important reason where you get a disproportionately low C4. So if you see that value, it can be a clue to you. Madam, please go ahead with any other questions on the investigation. Yeah.
No, it's all right. I think in one of my studies, we found that in patients of lupus who have got APSN, only limited to the renal disease, to the kidneys, they will always have low C3 and C4. So even if antiphospholipids are not seen in the kidney or in the circulation, if you do the kidney biopsies, you will find a macroscopic microvascular thrombosis in renal vessels. It was one of my studies, and they are the patient who will respond to rituximab. So from your reports, I think you got anemia in this patient, right? Hemoglobin was some 8 or
Yes,
something. You
yes,
have not
ma'am.
mentioned anything on ESR in this patient. How much was
Ma'am,
the
ESR,
ESR?
to at the ma'am, ESR at the time of arthritis was 90. Then the ESR was not done during 2022. Maybe it was done. She didn't have that. Current investigation, we got ESR done when she came to us. It was 70 when she came to us.
Okay. What happens to C-reactive protein in SLE?
Ma'am, it is towards the C-reactive protein is towards the lower side. It is because of high interferon, type 1 interferon. It can suppress C-reactive protein. So CRP can be lower side. If it is high, we must suspect for infections.
Okay. You said that the patient probably has CNS lupus, right? Because you said the patient had a seizure. Patient had a seizure.
Yes,
right?
ma'am.
In a
Patient had
patient,
seizure. Yes.
What does a seizure in a patient with lupus indicate? It's a normal thing. It's an emergency.
It
And
is
what is
an
the
emergency.
prognosis of such a patient? She's so
Ma'am,
young.
yes, ma'am. Ma'am, this patient could have seizure because of multiple reasons. At the time when she developed first episode, she was in nephrotic range proteinuria. There was anasarca. So this electrolytemia could have led. Plus, nephrotic is hypercoagulable state that could also have led to small ischemic strokes or maybe because of which she developed seizure. So there can be a
One minute. What was the blood pressure of this patient when she developed this stroke? This seizure?
Ma'am, we do not have that available because that was 3 years back, and she was admitted to some other hospital at that time. We don't know what the blood pressure was at that
If the
time.
blood pressure was very high, Anisha, suppose the blood pressure recorded was above the 99 percentile for the child,
Yes, sir.
hypertension,
Yes.
what would you relate it with the seizure? That's what madam was hinting at.
Ma'am, it can be due to hypertensive NCAF. It can be due to a small bleed. Anything could have occurred. But since there could be infections also that could have led to seizure, we don't know if at that time there was some infection.
No. The
No.
question, so Anisha, just
Yes.
listen to when the examiner or anyone, when we are putting the question, it's a clue combination that is given to you. So you
Yes,
will
sir.
not deviate from the clue combination. So if it is hypertension with seizure, then you answer only those because
Yes.
otherwise the next question would be that
Yes.
how do you justify the infection? And so it will just go on a different track. So hypertension with seizure, you said hypertensive encephalopathy, and somebody answered it correctly on the chat box. Posterior reversible encephalopathy syndrome can also be one of the manifestation of. Go ahead. So we are sort of nearing the time. There was a lot of things to discuss in this case, but we still have, I think, about 5 to 10 minutes before we will need to close. So, madam, other questions, maybe management, or even on the.
With the management. You can go with the management.
So at the time of anasarca, when she was admitted, the investigation report suggested that she was given 3 days of heavy dose of injectables, which were not mentioned in the report. But she was discharged on these medications. She was discharged on tab MMF, which was started initially.
Sorry,
Yes.
Anisha, again, I'm stopping you again. Literally, we don't want to know what has been done for
Yes.
this patient. We
What
want
is
your thought process and what would you do in this particular situation. So, in fact, the treatment part of what has happened is
she
not
was
necessary to put. Yeah.
yes, she was already treated with MMF. She was already treated with MMF when she came to us. She was and it was initially started with 500 and tapered down to 250 BD. But when she came to us, her proteinuria and UPCR were still very high. It was still UPCR was still 5.5. So I would like to shift her to injectable IV cyclophosphamide. and start with Euro lupus regimen of fixed dose. Since it is fixed dose for adult is 500, she being her body surface area only being 0.9, which 0.9, her dose came out to be around 270 to 80. So I would like to give her six doses of injectable IV cyclophosphamide 2 weeks apart, along with
If
uh, uh,
proteinuria is the only issue, and I can see the compliments have come up and other elsewhere, her disease is not very active. Would you have the option of any other medicine in mind along with mycophenolate mofetil, which you could
we can give
add?
calcium inhibitors, sir.
Very good. Yeah, we
Along,
can use
yeah,
calcineurin inhibitors.
yeah,
When the patient developed seizure and it was suppose a diagnosed lupus and you didn't have, you have excluded all the other possibilities,
yes,
metabolic, hypertensive.
yes,
Uh,
sir.
what would you
Infection.
want? One investigation in a case of lupus, which will be very helpful. Suppose it's a focal thing that you get on an MRI. What would you want to do? Which test is important in anybody who has a thrombotic episode? And hence the seizure.
Sir, we have to see for APLA
Workup. Very
and
good. Okay.
antiphospholipid
And if
antibodies
it's
we
not
can get.
focal and if it's diffuse, then what would be your treatment plan for assuming that this is a neuropsychiatric lupus? Now you have excluded the other possibilities, which is the most
Sir,
important step always. So what would you give?
Sir, neuropsychiatric lupus is it will require early immunosuppression. It requires active immunosuppression, and then we can rituximab has proved to be
No, and avoid generalized terminology like active
yes.
immunosuppression.
Sir, it
Use
depends whether the cause.
So you say, yeah, so you say, what, suppose
Uh,
this is an aggressive lupus with neuropsychiatric manifestation. What
we,
could you
I
treat?
we,
Yeah. Yeah, go
sir,
ahead.
I would give in sir, active immunosuppression would be required at that time. So we will give
Which one?
steroid
Yeah,
pulse,
very good.
steroid pulse. Yes,
Very
sir,
good.
and uh, then steroid pulse, and then we can give
You will need
I.
a drug. Do you need a drug that will cross the blood-brain barrier? What is basically the cause of CNS lupus? If the MRI or something was normal in your case, what is the direct causes of CNS lupus in SLE, and what
Ma'am,
are the
there can be
indirect
four
causes?
causes.
Listen.
Yes,
What are the
yes,
indirect causes of CNS lupus?
ma'am.
Will the
Indirect causes,
importance to direct causes or indirect causes, which are better, which are
ma'am.
amenable to treatment?
Indirect causes will be have a better prognosis because they can be treated accordingly. We can treat the underlying condition. There can be four causes, four pathogenesis in which neuropsychiatric lupus can occur. They can be due to vasculopathy, vasculitis per se, which is rare, and then if it is associated with antiphospholipid syndrome, it can be due to prothrombotic condition. Leading which would require other conditions, plus it could be due to presence of concomitant anti-NMO antibodies, aquaporin 4 antibodies. It could be because of that also. So neuropsychiatric lupus, when when vasculopathy is the cause and there is disruption of blood-brain barrier and a lot of cytokines and antibodies enter the central system, that has to be we have to rule out the other causes, and then SLE can be attributed.
Was your patient a candidate for plasmapheresis?
No, ma'am.
Why?
Ma'am, plasmapheresis would be needed if there is conditions that would require plasmapheresis would be mean if there is in lupus presence of DAH. Like you, ma'am, you want me to tell you through only the neurology?
Did you think of giving plasmapheresis to this patient or not?
No, ma'am.
No. Have you done a kidney biopsy in this patient?
Ma'am, we advised, but because of monetary issues, they could not get it done. But we advised a kidney biopsy.
How this kidney biopsy will help you? Because this
Ma'am, it
child
will
has
help.
from the age of 9. From the age of 9,
Yes,
probably
ma'am.
she's suffering.
Yes, ma'am.
Then,
Since yes, ma'am, the kidney biopsy is necessary because we have to classify our glomerulonephritis into related to SLE could have various classes. It could be minimal mesangial, it could be class 3, 4, which is focal and diffuse proliferative. Then 5, which is membranous type.
from the reports that you have, from the clinical
Yes, ma'am.
scenario you have, can you
Yes, ma'am.
possibly postulate which type of
Yes,
glomerulonephritis?
ma'am. Yes, ma'am. It looks like membranous. Because her urine creatinine reports are normal within all throughout these 3 years have always remained normal, and there was no associated oliguria, and there is no complaint of decreased urine output. Blood reports have heavy nephrotic range proteinuria, so membranous nephropathy usually presents as nephrotic syndrome. It could be class 5, ma'am, according to the reports and her history and examination. They indicate towards class 5.
What are the management strategies for class 5 lupus then? Because you invited a question.
Yes, ma'am.
Anisha, this will be your last question because we are now
Yes,
nearing time for the quiz. And
yes,
after you answer, please let us know what was the diagnosis of the abdominal pain that she
yes,
presented.
ma'am.
Okay.
Yes, sir. Sir, when a class 5, when a class 5 patient of lupus nephritis comes to us, we will see if the proteinuria is less than 2 grams or more than 2 grams. If it is less than 2 grams, we would only go with glucocorticoids and RAS inhibitors. We can use angiotensin receptor blockers. And if remission occurs and if it begins, the proteinuria starts to decline, we will continue the same treatment. If it does not decline, or if it is more than 2 grams at the initial presentation, like in her case, it was more than 3.5. So we would go for glucocorticoids plus MMF. And if we will check for, we have to check for remission after 3 months. If remission does not occur, we can add calcineurin inhibitors. We can either shift from MMF to IV cyclophosphamide, or we can give rituximab if we have both used MMF and cyclophosphamide later on.
Cause of abdominal pain and the
Yes,
dosage
ma'am.
that you got.
Yes, ma'am. The cause of abdominal pain was since all the 3 episodes of abdominal pain were always connected to lupus flare, and her abdominal CT report suggestive of diffuse wall thickening of the small intestine, the duodenum, the proximal.
What does the wall thickening indicate? It gives us a diagnosis and episodic pains.
Yes, ma'am. It towards mesenteric vasculitis and mesenteric ischemia was our diagnosis, ma'am.
Okay. I think that's over, Sunil.
Yes, ma'am. Lot of questions, more discussion in this case, but we are constrained due to time. And
other thing is she's junior also. No, she's also
yes,
junior, but
correct,
2-3
correct.
months. But
Yes.
still, she has done very well. She has done
Yes.
very.
So a minute of feedback, madam, from yourself, then from me, and then we will move on with the quiz because Anisha would also like to know how she did. So please.
I think she's good in her presentation. She knows how to take history, physical finding. What she wants, what she should work hard is to learn correlation and be oriented when the question is asked to any student.
Yes.
For that purpose. That orientation is very important. If you give a wrong answer, the questions will be fired to you. That is one thing. And when you say, once you finish your physical examination, you must come to some conclusion. When you interpret the report, you should conclusion. Like your patient, she got chronic anemia, is DSR, right? And proteinuria. So this indicates a chronic disease. That then the differential will come automatically. And when you plan the treatment, you have to take into consideration where the disease is dominant. Was it CNS lupus in your case? Was it abdominal pain or was it renal? But I think all the three things put together, they speak of lupus vasculitis. Basically,
Yes,
to
ma'am.
rule out thrombotic secondary to antiphospholipid syndrome. And lupus itself can give rise to vasculitis, which was not accepted one time. Please remember that the vasculopathy is totally direct because of in CNS. It could be direct in the intestine, and it could be the local inflammation plus the disease activation in what you called as the glomerular cell, even T cell deposition, B cell deposition. They themselves become reactive when there are so many antibodies. I think one question that everyone should remember, that even if the AN is negative in few patients, anti-Smith antibody, anti-Rho antibody, anti-DSDN antibodies, they will make a diagnosis of lupus. And I think for the long-term management and prognosis, kidney biopsy is a must. Imaging will tell us an active lesion or a past lesion, but this particular patient has got renal disease going on from the age of 9, and I think it is the responsibility of adult rheumatologists for a good treatment plan for her. That's my input.
Sure, thank you. Anisha, quick words from me. You presented very well, okay, and all the findings and everything. But I think you need to have a thought process or an analytical angle to it. So it was
Yeah.
very good presentation, but the analysis of your symptoms and then analysis of your set of symptoms is very important.
Yes.
Don't get biased by the diagnosis which is already there with you with investigation. In fact, probably at some time you change this pattern and not allow you to know what is the let the guide only give you the case and examination finding, because then it builds up the analytical process more. Otherwise, knowing the diagnosis just gets you biased and
Yeah,
stops you from lateral thinking. So that is where you have read and you have made efforts to answer all those questions. So that was good. Just try to uh, give them a little bit more efforts when you're seeing the cases to analyze the case, the symptomatology in a broader sense.
Yes,
Okay.
sir.
And then narrow it down with your findings to the differential. Well done. Okay.
Yes.
important is,
So,
I think, important for everyone, every student who is here. Syndromic approach to a case is very important. Syndromic approach. Patient started with the fever, pain, stiffness, joint pains, no? Then the patient has come to you. So the history starts from there, where the mistake was made.
Yes.
Or there are many issues, power kind of thing, patient, they don't comply with the treatment. Then you have to come down to a renal disease, right? So the onset and chronicity was important in this case. And once when the disease at 3 levels, three organs, we say it is a multisystemic disease, so vasculitis or lupus. But there are many chronic granulomatous illnesses which mimic lupus also.
right.
And I didn't like the word doughy abdominal fluid,
Yes,
because
ma'am.
that gives me TB, right? So you have to be very careful.
Sure.
Okay. Overall, it's a good attempt.
Yeah.
Thank you, ma'am.
All right.
Yeah.
So with
Yeah.
this, we come to an end of this first session. And then Dr. Sandeep, are you there? Are you
Yes,
ready
yes,
with
yes,
your difficult
yes,
questions? But I thought it was a fun
yes,
quiz.
yes,
So all the
yes, yes,
participants
yes,
for the
yes.
quiz are ready. And I hand it over to Dr. Sandeep from here, who's at Bharati Vidyapit, Pune. And I think we are all going to enjoy the quiz, Sandeep. Thank you. Take.
Yeah, yeah, yeah. So, thank you, Dr. Sushant and Bichide ma'am, for such a nice, productive case discussion. So, we are heading to next session. Yeah, हमारे fun quiz. We have a short time, so we'll run fast from here. So, first set of rules for the quiz. So we have got 5 participants for the quiz, and there will be 3 rounds for this quiz. I would like to welcome the participants. Let me check if all participants are here or not. Vaibhav,
Yes, sir.
please unmute. Yeah, please unmute yourself and put the video on. We would like to see your faces. Okay. Nikhila,
Yes, sir.
Kavya, is Kavya here?
Yes, sir. Yes.
Okay, okay. Please switch on your video. We would like to see you. Ankita.
Yes, sir.
Okay, welcome, Ankita. And Vrushal.
Yes, sir, I'm here.
Okay. So let me spell out the rules. Okay, it's a very short quiz. Only 3 rounds, 5 questions in each round, just 15 questions we are going to have. I request all other participants to stay mute throughout the quiz, and they should not use your chat box also. First round will be the 20 marks for the correct answer and minus 10 mark for the wrong answer. The compulsory pass will go to the next candidate in case of wrong or not attempted question. Understood? So for every pass question, so the pass, if the question is passed, then the correct answer will get 10 marks and minus 10 for wrong answer and 0 marks for not attempted. And after the first pass will go even if you are answered wrongly or not attempted, but further pass will only go for the non-attempted question. If the second person attempts it wrong, then question will stop there itself, then it will go to the audience. So time limit will be the 45 seconds after question is completed. And the quiz master's decision in this quiz will be final. So I have Akanksha with me as a scorekeeper. Akanksha, can you please show yourself?
Yes, sir, I'm there.
Okay, sure. So let's go ahead. So to decide this quiz, we'll arrange the participants as per their birthday months. Okay, I don't know anyone's birthday. So anyone in January? No one. February? No one. March? April? May? Oh my God, none of the participants in first 5 months of the year, their birthday. June? July?
Yes, sir, me.
Okay, so Kavyashri will be the participant 1. August? September?
Yes, sir.
September me also, sir.
Vaibhav. Okay. Vaibhav,
And
what's your
Vrushal.
birth date?
21, sir.
What is your birth date, Vaibhav?
21 September, sir.
And other participant?
29 September.
Okay, so Vaibhav will be the participant 2 and the participant 3
Vrushal.
will be, sorry, I couldn't see your name here.
Vrushal.
Vrushal will be the participant 3. Then October, Nikhila. Okay. And November,
So mine is November.
your is November. Okay, Ankita is November. Okay, so we are given random sequence to all 5 participants. Ankita, you
Yes,
got
sir.
it?
Yes, sir.
Okay, fine. So we'll go ahead now, here onwards. Okay, let's begin the quiz. So read your answers carefully. And I would say, since we have negative marking, answer only if you know it. Okay. So first question for participant 1. The 56-year-old man is referred by his GP with an elevated creatine kinase of 25,234. He gives a 2-month history of increasing upper and lower limb weakness and progressive shortness of breath, preventing him from his main pastime, which is hill walking. He has been well up to until this episode began and is on no medication. Neurological examination reveals bilateral upper and lower limb weakness and mild muscle tenderness. General examination demonstrates an elevated JVP to 5 centimeters and basal inspiratory crepitations. Heart sounds are normal. Initial investigations I'll show you. You can ask me to go back on the slides. Okay. So these are the investigations. You can go through the investigations. I'll wait here for a few seconds. Okay, Kavya?
Yes, sir. Yes.
Okay. You can anytime ask me to go back to the slide. And diagnosis of polymyositis is made. And given these findings, which one of the antibodies is most likely to be positive?
Sir,
Anti-EA.
option B, anti-Jovan antibody.
Okay, you want to log this answer?
Yes, sir.
Okay, so this is a wrong answer. I would like to pass the question to participant 2.
Sir, option C, sir, anti-OJ antibodies.
This is also wrong answer. So since we have got 2 wrong answers, I'll go to the audience. Which can be the antibody present over here? Look at
Yes,
the
sir.
investigations. Anyone in audience?
Anti-CRP, sir.
Anti-SRP.
SRP, sorry.
Yes, this is anti-SRP because look at the creatine kinase, very high creatine kinase elevation. Plus, look at the heart function, this global impairment of ventricular function. So, anti-SRP antibody is one of the antibody with a worse prognosis. Okay, so the correct answer in this question is anti-SRP. Nobody gets a mark. Both the participants get -10 over here. Okay. So for the participant 2, this question is for participant 2. You are asked to see a 72-year-old man on the urology ward who has developed polyarthritis affecting his right knee, ankles, and wrist. He had his third treatment with intravesical BCG chemotherapy for a transitional cell carcinoma of the bladder 5 days earlier. So on examination, his temperature is 38.1 degrees centigrade. He has a warm effusion at his right knee with a movement limited to 40 degrees of flexion, and he is unable to fully extend his knee. Ankles and wrists are also tender, but not swollen, and movement is normal. So I forgot to write here, unable to fully extend knees. Okay. And then ankles and wrists are tender and swollen, but movement is normal. He has no lymphadenopathy and rest of examination is unremarkable. These are the investigations. Okay. You can go through the investigations. I'll wait for 10 seconds over here. You can anytime ask me to go back to this slide. Okay, even after the question is asked. So, which of the following investigations would you like to initially request? Okay, aspirate joint and send for AFB, aspirate joint and send for crystal analysis, aspirate joint and send for gram stain, microscopy and culture, chest X-ray, and want to test.
I would like to go with option C, sir.
This is the correct answer because you have to follow the standard protocol. You have to rule out septic arthritis in this condition because his knee involvement is there, and with a movement limitation and warm effusion and fever, you have to rule out septic arthritis. Although the features are like post BCG reactive arthritis. Okay, but you should not forget the standard protocol for a warm, tender joint. Okay. So I would like to proceed to the next question for participant 3. Ready? So he's a 27-year-old woman seen due to various aches and pains. She takes no medication other than combined oral contraceptives. She has been generally well, but has had general muscle aches for a couple of years. There's nothing to note on physical examination, and she has normal height and normal secondary sexual characteristics. These are her investigations. I would wait here for 10 seconds and then we'll go ahead. Okay. So the question is, which of the following is the likely diagnosis? Factitious result, primary hypoparathyroidism, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, and secondary hyperparathyroidism. Would you like
I
to
would
look
pass
back
the
at the
question, sir.
investigation? Yeah.
I would pass the question, sir. I'm confused between two options, so I would pass the.
Okay, so question goes to the next participant, participant 4.
Just see previous slide once.
Would you like to answer?
Can I see the previous slide once?
You are not audible, Nikhila.
Can I see this slide?
So she wants
You
to
can-
see the slide.
Sorry, I couldn't hear her.
So she's saying, asking to see the previous slide.
Okay. I couldn't hear her. Yeah.
Secondary hyperparathyroidism, sir.
This is a wrong answer because in this question, This question will be passed to next participant. Participant 5.
I would like to pass it to other.
Okay, so it will go to participant 1.
Sir, I will also pass.
Participant 2.
Sir, could I please see the previous slide?
Yeah, you can see the previous slide.
Sir, could I see the options, please?
Yeah, you have got 10 seconds remaining with you.
I would also pass it, sir. Not sure.
Okay, so next participant, I think it was a question for the participant 3, isn't it? Akansha, we're done with everyone now?
We're done. It was for 3 only.
Okay, fine. So the answer to this question is a pseudo hypoparathyroidism, because in this thing we can see this parathormone is high, but calcium is low. Okay, so this is the case of pseudo hypoparathyroidism. So this was the correct answer for this question. Okay, so nobody could answer. I think Nikhila attempted it, but got it wrong. So you can give negative mark accordingly. So this participant 4, this question is for you. A woman in her 20s with a medical history significant for systemic lupus erythematosus presented with tender erythematous nodules after undergoing right knee arthroscopy. SLE has been diagnosed 10 years previously after she presented with a positive anti-nuclear antibody titer. Arthralgias, leukopenias, oral ulcers, and malar erythematous eruptions. The physical examination revealed poorly demarcated erythematous plaques and nodules, tender to palpation, ranging from distal thigh to lower leg, adjacent to arthroscopy site. The punch biopsy of the lesion was performed. So this was the lesion, and this is the biopsy finding in that case. Okay. And these are the options. What do you think is the most likely diagnosis? Cellulitis, tumid lupus erythematosus, gyrate erythema, or erythema nodosum?
So can I see the histopath image once?
Yeah.
Erythema nodosum, sir?
This is the wrong answer. There will be a pass for this question to next participant. Participant 5.
Sir, I would like to pass it.
Participant 1.
Sir, option B, tumid lupus erythematosus.
Correct answer. This is the correct answer. In tumid lupus erythematosus, classical finding is the sparing of epidermis. Here, if you see, the epidermis is not involved. In pathology also, epidermis is not involved. It's a pure dermis involved. And second thing, to differentiate it between erythema nodosum and tumid lupus, erythema nodosum is a classical paniculitis. Paniculitis means inflammation of fat. So there is no septal paniculitis. We can't see even fat globules here. So that's why the diagnosis of tumid lupus erythematosus is the correct answer. So Akanksha, give her a mark.
Yes, sir.
Yeah. So let's go to question 5 for the participant 5. A woman in her 40s with a history of atopy presented with 1 year history of asymptomatic red-brown patches on distal extensor extremities. The lesions began on the bilateral lower legs and spread to the thighs, buttocks, hands, forearm, proximal arms. The physical examination revealed numerous stellate red-brown patches without induration, scale, or ulceration. The review of systems was notable for episodic muscle cramping and numbness involving the lower extremities. The patient had no notable recent medical illness, illicit drug use, or new medications. An incisional wedge biopsy was performed on the lesion from the lower extremity. This is the lesion, and this is the wedge biopsy. So your question is what is your diagnosis based on these findings?
So can I see the question first?
Yeah, you want to see the history or
Yes, sir.
pathology?
History.
Yeah, this is history.
So options.
Sorry, your time got over. You don't answer now. Okay, this question get passed to the next participant. Okay. So participant 1.
Sir, option D, polyarthritis nodosa.
Correct answer. We will get a mark over here. So it is the correct option. So because this is a clue, the biggest clue was this histopathology slide. You can see a muscular artery over here, and it has got inflamed. So this is the medium vessel vasculitis, and this is the classical lesion for polyarthritis nodosa. And moreover, the clue was here. There was numbness involving the lower extremity. So there was neuropathy also. So this was one more clue that this was polyarthritis nodosa. Okay. So we have done with the round 1 for all the participants. Akanksha, can you announce the scores for everyone after round 1?
Yes, sir. Just 1 second. Sir, Vaibhav and Kavya, participant 1 and 2, both are at 10. Rest of them, all 3 of them are at 0 right now.
Okay. So there is ample of scope here from here onwards. So for second and third rounds, we'll show you the question first without options. And then we'll go, if you request options, then we'll give you options. So without options, if you answer, you get 20 marks. If you answer with options, you get 10 marks. If you don't answer, you get 0 marks. For wrong answer, again, minus 10 mark. So compulsory first pass will be given for wrong answer and not attempted questions. And further pass only for the non-attempted questions. Okay, correct? So for the pass person, we'll get 10 marks for the correct answer and minus 10 for the wrong answer. Okay. So the pass on candidate doesn't have option of getting 20 marks here. Okay, but he can request the options if not shown previously. Okay. So let's go for the participant 1. Ready?
Yes, sir.
Yeah. So see this person and what is the drug associated with this person?
Sir, options, please.
So these are your options.
Sir, I will pass.
Participant 2.
Pass, sir.
Participant 3.
Sir, pass.
Participant 4.
Pass, sir.
Participant 5.
I will pass, sir.
Okay, so all of them have passed. Now I'll go to the audience. Anyone can unmute and tell the answer. I'll be very happy. Yes, yes, yes. And who is this gentleman?
Yes, Paramjit Singh.
No, so this is not Paramjit Singh. Your answer is correct, but who is this gentleman?
Dr. Many, sir.
Yes, yes. This is Professor Ravindra Maini. All of us should be proud of Professor Ravindra Maini. He is an Indian origin UK citizen, and he discovered the use of anti-TNFs in the rheumatology setting. So he was the first one to use infliximab in rheumatoid arthritis, and that's why he's associated with this drug. And later on, he went on to receive knighthood for this purpose. So he is called Sir Professor Ravindra Maini. Okay, very important personality so far as Indian origin rheumatologists are concerned. Okay, participant 2, this is for you. The next question. This trio was related to which research work?
Sir, I would like options, please.
Okay, so these are the options for you. The glucocorticoids, aspirin, immunoglobulins, or physiology of thymus.
So I would go to glucocorticoids, sir.
Correct answer. This is the glucocorticoid because this is a Nobel Prize given in 1950 in the physiology or medicine category because these trio had discovered the role of glucocorticoids in inflammatory conditions. So very good participant two.
Yes, sir. Thank you.
So this is for participant three. What is this pathological feature? Look carefully. Okay, before you jump on to the answer. This has been the original image which was published when this pathology feature was described.
Can I see the options, sir?
Yeah. So hemophagocytosis, yellow cell, tart cell, or karyorrhexis.
Option B, Ellie cell.
This is the wrong answer. It will get passed on to the next participant. Participant 4, can you answer?
Tart cell, sir?
Yeah, this is the correct answer, tart cell. What is the difference between tart cell and yellow cell? Can anyone tell of all the participants what is the difference between tart cell and yellow cell? This is just a non competitive question. So what happens in yellow cell, this chromatin inside is not visible. It's a homogeneous consistency of the engulfed nuclear material. Whereas in a tart cell, it is always a macrophage like cell which is eating up another cell. Okay, so the chromatin structure is still maintained in tart cell. Yellow cell chromatin structure is not maintained, it is homogenized, and it's usually a polymorphonuclear cell. Okay, so this is difference. Karyorrhexis is the breakdown of the nucleus. This can happen before the apoptosis. And hemophagocytosis is the entity where RBC will be inside the phagocytosed cell. Okay. So Ankita, give her a mark.
Yes, sir.
So this is question 9 for the participant 4. If you're well versed with the movies, which movies this movie is related to which disease? Any idea? Or would you like to go for options? Okay, so time up. So question get passed on automatically to the next participant. Participant 5.
He would like to pass it.
Participant 1.
Sir, options, please.
So these are the options for you. Participant 2.
Sir, lupus.
Yes, correct. So this is a movie on lupus where the actress has got lupus. Very nice and popular movie, Beyond the Universe. Recent movie. If you have not seen, it's you can watch it for the academic purposes. Okay. The next participant, question 5, participant 5. This question is for you. Which autoimmune disease this celebrity is related to?
So Sjogren syndrome.
Very correct. So you will get full 20 marks for this question. Ankita, we're done with
Yes.
round 2. So scores, please.
Sir, Rushal is at -10, Vaibhav at 20, Nikhila at 10, Ankita at 20, and Kavya is yet to score 0.
Okay, fine. So no problem, no problem.
No, sir,
You still have.
I scored
Yes.
10 in last round.
Oh, yes,
Ankita,
sorry.
please
Yes.
resolve, Ankita.
10 for Kavya, sir. Sorry, my mistake.
Okay, fine. So I'll go ahead now with the next question to the participant 1 again. So identify this lung condition, and hint is here that this is responsive to glucocorticoids.
Sir, options, please.
So these are the options.
Sir, option A, hypersensitivity pneumonitis.
This is the wrong option. Question gets transferred to participant 2.
Sir, this is C, option C.
Correct answer. So you will get 10 marks over here. Okay, so this is cryptogenic organizing pneumonia. In hypersensitive pneumonitis, you get reticulonuclear shadows, not like this. Vanishing lung emphysema is a ruptured bullous emphysema. Okay, diffuse alveolar hemorrhage has a different kind of finding altogether. Moreover, CT will be different in DH. So this is cryptogenic organizing pneumonia, and it is very responsive to glucocorticoids. Okay, so let's go to participant 2. So this is your question. What is the diagnosis based on this? This is technetium bone scintigraphy. Look here, there are 2 images. One is shot in 2007 and another one is 2008. Okay, there's difference between these 2 images a little bit, maybe before and after treatment, and you have to tell the diagnosis.
Sir, could I have options, please?
Yeah, so these are the options for you.
Sir, I would like to pass this.
Okay, so next participant 3.
Option B.
Yes, correct. This is the CRPS. The most important is this asymmetry in the involvement. And this asymmetricity score is actually used to describe the differentiation between polyarthritis because of rheumatoid arthritis or CRPS. So this asymmetry score is very important. In case of CRPS, you will see gross asymmetry as opposed to rheumatoid arthritis, which shows similar involvement on bilateral sides in most of the situations. So this is CRPS, and this is the modality used for its diagnosis. Very good. So Ankita, give him marks. So question for the third participant, what is the diagnosis of this condition?
I want options, sir.
So these are the options for you.
Option B.
Correct answer. This is, what is FMD?
Fibrous muscular.
Yes. So this is correct answer. Ankita, give him marks. Okay. So he will get 10 marks after the options. Okay, so next question for the participant 4. What is the logical next step in the imaging? Okay, You will have to clearly describe the imaging, if it is contrast, non-contrast, or whatever else imaging you want to do. Okay. Or whatever agent you use for enlightening the things. Okay.
CCT, KUB, sir. I mean,
Okay, you want to do contrast enhance CT KUB. This is correct answer. So if not given answers, this is the correct answer. If you would have seen the answers, I have deliberately included. Can you try among this which will be a better answer? You will get full marks for this question, no problem. What do you think among this? If the non-contrast CT would have been in options? Then MRI becomes the most important logical next step. What is it? What is this condition? Could you identify the condition?
Retroperitoneal fibrosis.
Yes, this is retroperitoneal fibrosis. Although I'm not sure whether she has got this condition or not, but her answer is correct. So there are two modalities which you can use, either contrast CT or MRI. Okay. So this was for participant 4. And we'll go to the participant 5. So this is the question, 55-year-old lady with right shoulder pain. What is the most likely reason? Okay, look at the image and guess the diagnosis. Okay. Look at the image carefully.
Can I have an option?
Yes. So these are the options.
So avascular necrosis.
This is the wrong answer. This will get passed on to the next participant. Participant 1.
Sir, I will pass.
Participant 2.
Pass, sir.
Participant 3.
Option B, sir. Erosive arthritis.
Wrong answer. Wrong answer. No more passage. So can anyone in the audience can unmute and answer this question? What is remaining? Osteomyelitis and malignancy. Okay, so let me answer this question. Look at the breast shadows. I think nobody would have paid attention to the breast shadows. Where is the other side breast shadow? She's a post-mastectomy patient. Okay, and all these are lytic lesions in the shoulders. So this is actually malignancy. Okay, metastasize from this side of breast carcinoma. Okay. So Nikhila, Akanksha, can we have the scores after 3 rounds are done? So we'll get winner over here.
Okay, sir. Just a second. Sir, after round 3, Rushal is at 0, Vaibhav is at 30, Nikhila at 30, and Ankita again 0, and Kavya also 0.
Okay, so we have a tie over here between Vaibhav and Nikhila. Isn't it?
Yes, sir. Same score.
Okay, so let's have a tiebreaker. Okay, Vaibhav and Nikhila. Vaibhav participant 3 and Nikhila is 4, na? I think.
Sir, I think I've gotten 40, sir.
Where 2. No, that was a past question, so you got 10 for that. So it's 30. So Vaibhav is 2, sir, and Nikhila is 4.
Okay, so Vaibhav, this tiebreaker question is for you. So rule for the tiebreaker is 20 mark for correct answer, minus 10 for wrong answer. Okay, and the same marks for past answers. Past answers will also get 20 here. Okay, Ankita, note the change in rule now. Pass mark will get full 20 marks. Okay. So pass for both wrong answer and not attempted. Even if you answer it wrong or not attempted, it will get passed compulsorily. Okay. Vaibhav, Nikhila, ready?
Yes, sir.
So there will be no options. This will be without option questions. So 27-year-old lady with lupus receiving cyclophosphamide develops painless progressive loss of vision for over 4 weeks. What is the most likely etiology? This is for Vaibhav.
Pass, sir.
Pass. Nikhila, can you answer?
Pass, sir.
Okay, both of you couldn't answer. Anyone else can answer this question? What do you think looking at the fundus appearance? This is very typical of CMV retinitis. Okay, here you can see the tomato ketchup appearance, and you can see the perivascular infiltrations, which are very typical of CMV retinitis, and it is common in immunosuppressed patients. Okay, so the question couldn't solve the tie. Now this question is for Nikhila. So what is the most likely diagnosis in this case? Nikhila, can you answer?
Uh, is it bilateral sacroiliitis, sir?
This is the wrong answer. Vaibhav, you get a chance.
Sir, can I get options for this?
No, there are no options for this round.
Sir, is it hernia, sir?
No, both are wrong. We're still unable to break the tie over here. Okay, so this, anyone else can tell the answer. This is not that difficult.
Avascular necrosis.
Osteomalacia.
Yeah, this is the osteomalacia. Very simple. You can see the fracture neck, femur, the pseudo fractures at the neck area. Okay, so this is the osteomalacia. Okay, so I think this is Vaibhav's turn, na? Or Nikhila's turn. So
Vaibhav's.
question 18, Nikhila's turn, huh? No, sorry, Vaibhav, it's your turn. I'm sorry. What is this sign in this X-ray abdomen? Can you appreciate?
Um,
Okay.
sir.
But appreciate, then we pass. Nikhila, can you appreciate? Can you appreciate which sign is this?
Is it pneumonitis intestinalis, sir?
No, this is not pneumatitis intestinalis. Anyone else in the audience or in the other participants can answer?
Corkscrew sign.
No, this is not corkscrew sign.
Sentinel loop sign, sir.
No, this is thumbprinting sign. Okay, you can see the thumbprints over here. Can you appreciate thumbprints? Here, these are the thumbprints here seen. Here you can appreciate the. So these are the thumbprints in the. Where is it seen? Thumbprinting sign.
Lupus enteritis.
Yes, lupus enteritis. Other option can be ulcerative colitis. In both, it can be seen. This is thumb printing sign. Okay, we couldn't break the tie. I hope we don't want to have to announce joint winners. There are two more questions for tiebreakers. Okay.
There was some minus score for wrong answers in this session. Then Nikhila.
Okay. Well, then fine. Then we'll be able to resolve. I would like to still go further with the tiebreaker questions.
Sure, sir.
Okay. So this will be a last tiebreaker question for Nikhila. Okay. Nikhila.
Yes, sir.
So can you tell this diagnosis? All of you have learned about this condition.
So,
Pass?
yes, sir.
Okay, Vaibhav, can you answer?
This is primary hypertrophic osteoarthropathy, sir.
Correct answer. This is hypertrophic osteoarthropathy. Vaibhav gets a mark over here. Akanksha, could you resolve the tie?
Yes, sir.
Okay. Then we'll stop our competition here itself. This is the last bonus question for all the participants and audience. See, so this is the condition. This sign is associated with which condition? This is non-competitive question. Okay, anyone can answer.
Hatchet facies myotonic dystrophy.
No. Which sign is it? Something eye sign.
Raccoon.
Raccoon eye sign. Very good. Senile? Amyloidosis. Okay. So this was the last question of the session, which I had kept for rapid fire, if in case the tie would not have been solved. Okay, so Akanksha, can you please spell out the results?
So at the end of the tiebreaker, sir, Vaibhav is at +10 and Nikhila is at -20. So
okay, so we have got a winner over here. So Vaibhav, congratulations. So congratulations for winning this small fun quiz. I thank all the participants and all the audience for joining me on this fun quiz. So now for quiz is over from my side. Thank you for all the participants for participating in this quiz.
Thank you, sir.
Thank you,
Okay,
Sandeep. Wonderfully conducted quiz. Kept me engrossed. Good mix of history and mystery. So it was very nice. I think the participants must have enjoyed, and not just those 5, but the rest of the candidates must have also
yes,
enjoyed it.
Intention was just this so that they could enjoy the rheumatology. That just
Absolutely.
starters. I was not expecting much, but they could get a hang of the discipline.
Sure. Thank you so much. So
lot of efforts by Kansurkar. I also enjoyed it.
Thank you.
Yeah.
Thank you.
Thank you very much.
yeah, so thank you everyone for participating today, and I think we'll call it a day off now.
Thank you everyone.
All right. Yeah, and thank you.